Hello, everyone. My name is Jeffrey Davis. I'm the Director of Regulatory Affairs at ACEP. I just want to welcome everyone to the webinar today to discuss telehealth and EMTALA with CMS. As you all know, CMS earlier this week made some very exciting and important announcements that will definitely impact emergency physicians. So this is a great opportunity to hear the highlights of those announcements and answer any of your questions. Without further ado, I wanted to introduce Dr. Rina Diseja, an emergency physician who's at CMS. Rina, please take it away.
Thank you, Jeff, and good afternoon, everyone. As Jeff mentioned, my name is Dr. Rina Diseja. I'm a board-certified emergency physician, and I currently am at the Centers for Medicare and Medicaid Services. I am the Chief Medical Officer of the Quality Measurement and Value-Based Incentives Group in the Center for Clinical Standards and Quality. The purpose of today's webinar is to provide updates, in particular on EMTALA as well as telehealth for emergency medicine providers. We were approached by the American College of Emergency Physicians to spend some time to walk through some of the changes that have been implemented in light of the COVID-19 crisis. Before we go through those changes with regard to EMTALA and telehealth, I wanted to spend a few minutes sharing with you CMS's efforts to date in responding to this crisis to support our frontline providers and patients. When President Trump declared the national emergency on March 13th of this year, CMS has been taking action nationwide to aggressively respond to COVID-19 under the direction of our administrator, Seema Verma. CMS has issued a sweeping array of new rules and waivers of federal requirements to ensure that local hospitals and health systems have the capacity to absorb and help effectively manage these potential surges of COVID-19 patients. The actions announced earlier this week introduced flexibilities to permit hospitals and healthcare systems to act as coordinators of healthcare delivery in their areas. I want to highlight some of the actions that CMS is taking to help providers address patients' needs during the pandemic. One includes increasing hospital capacity. CMS is allowing healthcare systems and hospitals to provide services in locations beyond their existing walls to help address the urgent need and expanding care capacity and to develop sites that are dedicated to COVID-19 treatment. Under CMS's temporary new rules, hospitals will be able to transfer patients to outside facilities. These include ambulatory surgery centers, inpatient rehabilitation hospitals, hotels, and dormitories, while still receiving hospital payments under Medicare. For example, a healthcare system can use a hotel to take care of patients needing less intensive care while using its inpatient beds for COVID-19 patients. Ambulances also can transport patients to a wide range of locations when other transportation is not medically appropriate. These destinations include community mental health centers, federally qualified health centers, physician offices, urgent care facilities, ambulatory surgery centers, and any locations furnishing dialysis services when an ESRD facility may not be available. The new CMS guidelines also allows healthcare systems and hospitals and communities to set up testing and screening sites exclusively for the purpose of identifying COVID-19 positive patients in a safe environment. The guidance describes circumstances in which hospital emergency departments can test and screen patients for COVID-19 at drive-through and off-campus test sites. Second, I want to emphasize that we also are working hard to think through how do we rapidly expand the healthcare workforce. CMS wants to add depth to the healthcare workforce since doctors, nurses, and others on the front lines are really being challenged like never before. CMS is issuing a blanket waiver to allow hospitals to provide benefits and support to their medical staff. This includes such as multiple daily meals, laundry service for personal clothing, and child care services while physicians and other staff are at the hospital providing patient care. To help teaching hospitals quickly expand their workforce, medical residents also have some flexibility in providing services on the direction of their teaching physician. Teaching physicians can now provide supervision to residents, for example, virtually using audio and video communication technology. And we're going to spend some more time talking about telehealth, but I want to briefly say that we also are promoting telehealth and Medicare and expanding these services for people with Medicare. This means that they can receive care where they are. So that's, at their home or in a nursing or assisted living facility. If a patient has COVID-19, they can remain in isolation, which will help contain the spread of the virus. If they're not affected, they can also get care without risking exposure to others who may be ill. So CMS, and we'll go into this more detail, will be paying for more than 80 additional services when furnished via telehealth. And we'll go into more depth on this shortly. Finally, I just wanted to share that CMS is also applying a policy to our quality and reporting programs, in particular with MIPS in response to COVID-19. In addition to extending the 2019 MIPS data submission deadline to April 30th of this year, the MIPS is applying the automatic extreme and uncontrollable circumstances policy. And what that means is that if MIPS eligible clinicians are not able to submit their data by the extended deadline of April 30th, they will not be held harmless. They do not need to take any additional action to qualify for the policy, and clinicians will automatically be identified and receive a neutral payment adjustment for the 2021 MIPS payment year. Because this extreme and uncontrollable circumstances policy legally is only applicable at the individual clinician level, if providers are submitting via a group, I do want to notate that if a group does not submit data, and then the individual clinicians also do not submit data, then the policy will apply to all clinicians in the group. Now, if the group has already submitted some of this data on behalf of the clinicians in the practice, but they won't be able to complete submissions and want to receive a neutral payment, they will need to submit an application citing this COVID-19 concern. And more information on all of this is really on qpp.cms.gov, and encourage you to look at that. As far as all the other policies, you can also access that under our webpage, CMS Emergencies. Before I hand this over to our CMS colleagues, I want to introduce those that are on the call. First, I want participants to know that we have Dr. Richard Wild on the call, who's the Chief Medical Officer for the Atlanta and for Atlanta and Boston, as well as the Regional EMTALA Enforcement Lead. He's a fellow of ACEP and is board certified in emergency medicine. We also have Karen Tritz, who's the Director of the Division of Continuing and Acute Providers in the Quality and Safety and Oversight Group. We also have Sarah Bryce Payne, who is the branch manager in that same division, as well as Jennifer Milby, who's the subject matter expert in that division. And finally, we have Ryan Howe, who's our acting deputy director for the hospital and ambulatory group for the Centers for Medicare. With that, we will plan to have some questions and answers available at the end of the briefing today. But I first would like to hand it over to Jennifer Milby to go over the EMTALA updates. Jennifer Milby?
Thank you, Rena. Thank you, everyone, for your time today. We really appreciate the opportunity to be with you today to highlight our recent revisions to the EMTALA QSO memo and answer any of your outstanding questions. However, in the essence of time, and to make sure we have ample time to answer all your questions at the end of the presentation, we will go ahead and jump right into the overview of the recent revisions to the EMTALA guidance, which was released on March 30th via the QSO memo 2015. So the memo provides additional guidance on 3 key points. The first point that we'll review is the drive-through testing sites. And the highlights with the drive-through testing sites are drive-through testing sites that have been established for the COVID-19 testing alone, including those being on a hospital campus, do not have EMTALA implications. However, EMTALA would still apply if a patient who was seeking only COVID-19 testing made a request for emergency medical treatment or appeared to have an emergency medical condition while on hospital campus. So that's kind of our gist with the drive-through testing sites, kind of short and sweet. And again, I'm happy to answer any questions at the end of the presentation. Moving on to the second key point of our memo revisions were expectations in relation to the triage process and the medical screening examination. So some of the key points under this that we would like to call your attention to is the triage in itself is the process of sorting individuals based on their need for immediate medical treatment. and is not considered to be a medical screening examination in and of itself. And I think you guys are probably all well aware of that. It is appropriate for hospital staff, however, to triage individuals for purposes of directing them to the appropriate location of the hospital where the medical screening exam will occur. And this would be based on the hospital's triage and alternate screening protocols. The hospital is still obligated to provide a medical screening exam to every individual who comes to the hospital for examination or treatment for a medical condition to determine if the individual has an emergency medical condition. If there is no emergency medical condition that's determined after the medical screening exam, the hospital's EMTALA obligation would be ended. Okay, so the other key point there is that the medical screening exams do not have to take place in the ED. A hospital may set up alternative sites on its campus to perform the medical screening examinations as well. The content of the medical screening exam can vary according to the individual's presenting signs and symptoms. It can be as simple or as complex as needed to determine if an emergency medical condition exists. The medical screening exams must still be conducted by qualified personnel, which may include physicians, nurse practitioners, physician assistants, or RNs who are trained to perform the medical screening exams and are acting within their state scope of practice act. If during that evaluation an emergency medical condition is determined to exist, the hospital must still treat and stabilize the emergency medical condition within its capability and capacity, including admitting the patient if needed, or transferring the individual to a hospital that has the capability and capacity to stabilize that emergency medical condition. The third point of the QSO memo revisions was one that I think we have a lot of interest in, and Ryan is going to cover this in more detail after our EMTALA presentation, but just a couple key points regarding the use of telehealth. Most of this information, the hospital, may use telehealth equipment to provide the medical screening exam by the qualified medical professional. So the QMP may be on the campus using telehealth, or they also may be off-site due to staffing shortages as well. The QMP must be performing within the scope of their state practice acts and approved by the hospital governing body to perform the medical screening exams. However, when telehealth is used to provide evaluation of individuals who have not physically presented to the hospital for treatment, this does not create an EMTALA liability. Okay, so those were just a few, I know, fast and furious key points of our memo revisions. And we're going to also move on to some further clarification of our overview of what the on-campus versus the off-campus alternative screening sites. So we had a few questions about that, and we wanted to try to make it clear to differentiate what was required versus on-campus versus off-campus. So for an on-campus alternative screening site, there's actually no waiver that is required in this instance. The medical screening exam does not have to take place in the ED. A hospital may set up an alternative site on its campus to perform the medical screening exams. Individuals may also be redirected to these sites, and whether the individual is seen at the alternate on-campus site or in the ED, they should be logged in wherever they are seen. The personnel providing the redirection from the ED should be a qualified registered nurse to recognize individuals who are obviously in need of immediate medical treatment in the ED. Otherwise, hospital non-clinical staff that are stationed at other entrances to the hospital may be able to provide the redirection to the other on-campus screening locations for individuals who are only seeking COVID-19 testing. Moving on to our off-campus alternative screening site requirements under hospital controlled, just a few key points here that we wanted to highlight. Hospitals and community officials may encourage the public to go to off-campus sites to be screened for COVID-19 testing instead of the hospital. Normally, a hospital may not tell individuals who have entered an ED to go to an off-site location for medical screening exam. So if an individual has presented to the ED requesting a medical screening exam in this instance, they would still be required to perform a medical screening exam and ensure an emergency medical condition did not exist. The hospital should not hold the site out to the public as a place that provides care for emergency medical conditions on a general basis, urgent basis, or an unscheduled basis. However, they can hold this out as a respiratory or potential presumed COVID-19 patient screening center. And with that as well, the off-campus site should be staffed with appropriate medical personnel trained to evaluate individuals with respiratory or potential presumed COVID-19 symptoms. If an individual presents to one of these locations off-campus and requires additional medical attention on an emergent basis, it is expected that the hospital is required, still under the medical conditions, Medicare conditions of participation, to arrange for referral, transfer, and prior coordination with the local EMS system would be highly recommended to ensure a transportation strategy is in place. And last but not least, something that we're again hearing more and more of popping up are the fact that communities or hospitals may also set up testing stations at sites that are not under the control of a hospital. And this could be in places such as a mall parking lot, retail center. I think we've all heard in the news that some of these communities and hospitals are setting up drive-by screening sites and emissions testing facilities as well. So it seems to be becoming more and more popular. And in these situations, there is no EMTALA obligation at these sites, even if the hospital personnel assist with the testing. Hospitals and community officials may encourage the public, again, to go to these sites instead of the hospital for COVID-19 testing. However, as we have discussed previously in the other options, a hospital may not tell individuals who have already come to its ED to go to an off-site location for the COVID-19 testing until they have been provided a medical screening exam and determined not to have an emergency medical condition. Communities and hospitals are encouraged to staff the sites with medical personnel who are appropriately trained to evaluate individuals with respiratory or potential presumed COVID-19 symptoms. And there should also be protocols or a process in place with patients who arrive in medical distress and may need transport to a hospital. And we know this may be as simple as calling 911. So I know that was probably a fast and furious review of our guidance overview, but I want to make sure we have time to move on into our next overview of the transfers and stabilization requirements that were also clarified during our recent memo release. And I'm going to turn that over to Sarah Bryce-Payne to review.
Thank you, Jennifer. We were asked to just kind of do a quick overview of the transfer and stabilization requirements. Hospitals with the capacity and the specialized capabilities needed for stabilizing treatment are required to accept appropriate transfers from hospitals without the necessary capabilities. However, the receiving hospital may refuse to transfer if they do not have the capacity to provide the necessary care and services. Hospitals should coordinate with their state and local public health officials regarding appropriate placement of individuals who meet the specified COVID-19 assessment criteria and the most current standards of practice for treating individuals with confirmed COVID-19 infection status. All Medicare participating hospitals with specialized capabilities are required to accept appropriate transfers of individuals with EMCs if the hospital has the specialized capabilities and individual required for stabilization, as well as the capacity to treat these individuals. This recipient hospital obligation applies regardless of whether the hospital has a dedicated emergency department or not. Hospitals with specialized capabilities, with or without an ED, may not refuse an appropriate transfer under EMTALA if they have the capacity to treat the transferred individual. Stabilizing treatment means, with respect to the emergency medical condition, to provide such medical treatment of the condition necessary to assure within reasonable medical probability that no material deterioration of the patient's condition is likely to occur. Once an individual is admitted to the hospital or the emergency medical condition is stabilized, the hospital's obligation under EMTALA ends. In the case of individuals with suspected or confirmed COVID-19, hospitals and CAUS are expected to consider the current guidance of CDC and public health officials in determining whether they have the capability to provide appropriate isolation required for stabilizing treatment and or to accept appropriate transfers. In the event of any EMTALA complaints alleging inappropriate transfers or refusal to accept appropriate transfers, CMS will take into consideration the public health guidance in effect at that time. So as you can see, there were not a lot of changes made to the transfer and stabilization requirements. Okay, before we move on to telehealth, I would like to answer some of the questions related to EMTALA that were submitted by participants previously. The first question was, does the hospital have to initiate its disaster plan before the waiver becomes effective? If the waiver has been issued in accordance with Section 1135 of the Act, it becomes effective upon the date of the 1135 declaration and may be retroactive. The recent flexibilities and blanket waivers released by CMS are retroactive to 3/1/2020. In cases when the waiver is cleared due to a pandemic infectious disease, the waiver will be effective until termination of the public health emergency. Our next question was, will CMS require notification that the hospital has initiated its disaster plan prior to implementing its MSE redirection plan? The answer to that is no. Hospitals are not required to provide notification to CMS upon initiation of their disaster plan. The next question is, can CMS confirm that each of the following is true? If the hospital discontinues its disaster plan, the waiver ends and is revoked. The answer is no. When a 1135 declaration is made due to a pandemic infectious disease, the waiver will be effective until the termination of the public health emergency. Next question was, if the state ends its emergency plan, the waiver ends. No, not necessarily. The 1135 waiver will be effective until the termination of the applicable public health emergency, which may be independent of the state's determination. The next question is, assuming that the hospital maintains its disaster plan and the state its emergency plan, the waiver will remain in place as long as the federally declared public health emergency is still in place. The response to that is yes. The 1135 waiver will be effective until the termination of the applicable public health emergency declaration. Another question was a discussion around potential liability protections for frontline providers during the national emergency. Unfortunately, this is out of the Quality and Safety Group's scope, but from our perspective, facilities must continue to follow the applicable COPs and EMTALA requirements that have not been waived. Okay, next question. Please describe what happens if states have already tried to individually pursue 1135 waivers to EMTALA. Can states still apply for waivers? What happens to waivers that have already been approved? Okay, state waivers are state-specific waivers are separate from federal waivers of federal requirements. For federal waivers of federal requirements, CMS has assembled a national team to assist with monitoring and retrieving and responding to all 1135 waivers related questions as soon as possible. Any 1135 waiver questions or individual provider requests may be submitted to the 1135 waiver mailbox, which is 1135waiver@cms.hhs.gov. And CMS continues to evaluate the need for additional determinations for individual and blanket waiver requests on an ongoing basis. Next question, has EMTALA been broadly waived? CMS has approved via the 1135 waiver for the COVID-19 pandemic the ability to redirect patients to an off-site location for screening in accordance with a state emergency preparedness or pandemic plan. So no, EMTALA has not been broadly waived. The specific items that were waived are outlined in the 1135 waiver. Next question. What is the communication strategy for disseminating information about changes to EMTALA? Any formal guidance, revision to existing guidance, or additional clarifications will continue to be released via the QSO memo or another CMS-approved communications avenue. Please refer to the CMS website, which has direct links to the coronavirus information. All right, given different ways that hospitals are trying to triage and treat patients, please clarify the definition of on campus. Well, under normal circumstances, the definition of campus per 413.65b means the physical area immediately adjacent to the provider's main buildings, other areas and structures that are not strictly contiguous of the main building or are located within 250 yards of the main buildings and any other areas determined on an individual case basis. Hospital property means the entire hospital campus, including the parking lot, sidewalk, and driveway, but excluding other areas or structures of the hospital's main building that are not part of the hospital, such as physicians' offices, rural health centers, skilled nursing facilities, and other entities that participate separately under Medicare, or restaurant shops or other non-medical facilities. However, we know that under the pandemic, non-hospital properties are becoming extensions of hospitals, such as hotels, dormitories, and parks. This is permissible under the 1135 waiver, and we would refer you to our description of temporary extension locations. It is acceptable to triage and treat patients off the normal definition of a hospital campus. Okay, I know that was quick, but those are some of the questions that we received prior to the call. I will now hand it over to Ryan to discuss telehealth.
Okay, thank you very much. Like everyone else, I'm certainly happy to be here to be able to share some of the information with you and happy to answer whatever questions I can. I work in the Center for Medicare, and we handle the payment policies for Medicare fee-for-service. And so I do want to say that the changes in rules that I'm talking about really only apply directly to the Medicare fee-for-service program. And so for both MA and obviously for non-Medicare patients, individual payers may have their own rules. That said, I did want to highlight a number of the changes under Medicare fee-for-service with relation to telehealth specifically. By way of context, as you probably well know, Medicare telehealth services prior to several weeks ago were really described a pretty small set of services primarily furnished to patients in rural areas and also primarily only when the patient was in a healthcare setting. So the payment policies and the billing mechanisms used for telehealth services really reflected that statutory construct that, generally speaking, telehealth was really about access to specialty care, for example, or where there was a particular access concern, primarily in rural parts of the country. And over the past month, while the system obviously and all of you are facing the challenges that you are, what we've been trying to do in the telehealth space to be as supportive as possible is to make changes recognizing that the circumstances on the ground are changing quickly, and that the use of telehealth and telehealth technologies can possibly play a critical role. And that started with changes in law that allowed HHS to make significant changes to the Medicare policy for telehealth services, including expanding telehealth to services across the country, not just in rural areas, as well as in all settings of care, including the patient's home. And those changes were made by the Congress, allowing Secretary to make that change, and we made that change several weeks ago. Subsequent to that change, we issued what's called an interim final rule, so that we made changes to our regulations to account for several needs as stakeholders had requested them, including emergency department physicians, but all parts of the system. Our goals here were to try to be as expansive as we could within our authorities, to make sure that whatever use of telehealth technologies could be helpful, that Medicare payment rules weren't standing in the way of the best use of those technologies. And so I think it's important just to put that out as the context. And that's also to say that we continue to explore our flexibilities, and we're certainly interested in continuing to hear what, if any, changes we need to make to allow you the most flexibilities to take care of patients and yourselves as best you can. And the other point that I would make with all of these changes is that these are by way of the Medicare system and at the speed with which we are sort of used to working. These are really rapid changes, and so I can talk about what the policy changes are. I think throughout the system, sort of the filtering down, and then through the claims processing systems, through the educational systems, through the Medicare administrative contractors. These are policy changes that are still being implemented over what's a relatively short period of time. And so we're both eager to hear about problems where they may not be implemented from a payment perspective as smoothly as they can be, and also beg your patience with some of that because the changes are so rapid. That said, I do want to cover several changes, highlighting some of the changes in the interim final rule that I think are most useful for you, and as well as in order to address some of the questions that we got in advance, which was very helpful. So I'll just kind of go over some highlights. First, historically, Medicare has maintained a list of telehealth services. These are the list of HCPCS codes or CPT codes that can be furnished or can be billed under Medicare fee-for-service when furnished via telehealth. That was a list of about, I think, 80 or 90 codes. What we did in the interim final rule was to add another 80-plus codes to that list. And included in that list are emergency department visits. There are several other institutional E&M visit codes, as well as many other services. We tried to be as expansive as we could, keeping in mind that the telehealth list is really for services that ordinarily would be furnished in person, but under some circumstances, in this case, broadly, may be able to be furnished via telehealth technologies. One other thing that we did that was pretty significant, I think, and is related, is to change the rules so that we pay for Medicare telehealth services what would have been paid had the service been furnished in person. And this gets at to a question that we've been getting a lot, and I know some of you have had, and that is, how do you bill for which service based on the location of the patient and the location of the practitioner? And I think as a matter of a policy principle, we are suggesting that practitioners should report the code that most or best describes the kinds of care that they're furnishing, and that would be without regard to the location of either the practitioner or the patient. So if, for example, you're furnishing an emergency department visit by a physician who is for isolation or whatever other reason in a different location, you would still report the emergency department evaluation and management code if that code best describes the work that you're furnishing. The same would be true if the patient were in the emergency department, if the patient were at home and the physician were in the emergency department. It may even be that neither are literally located in the emergency department, but if that's the level of care and that code continues to describe the best or most accurately the kind of care that's being furnished, that's the code that should be reported. We are requesting that in billing telehealth services now that the CPT modifier 95 be used as opposed to the place of service code for telehealth. That'll help with the claims processing systems because these changes are coming very quickly, and so we think our systems are in better condition to deal with the modifier than the place of service code, and that will also allow the place of service code to dictate which payment rate by way of the setting of care is most appropriate. Along those same lines, we've gotten a lot of questions about something that I know that is really important with the previous discussion as well. Can services be furnished via telehealth technologies when the patient and the physician or the practitioner are in the same location but may be separated for whatever reason, including and especially isolation? But if they're in the same hospital, for example, but are in different rooms and they use telehealth technology, can that be done and can that be reported via telehealth? And I think the best answer that I have right now is that telehealth really applies when the patient and the physician are in different locations. That's the way the statute defines telehealth. While that said, there's nothing to prevent from a Medicare payment policy perspective when services happen in the same location. There's nothing in the payment rules that would prevent the services that are furnished via communication technology in different rooms from being reported just like any other service. In other words, the telehealth rules themselves don't apply, but that doesn't mean that the visit codes, for example, wouldn't be appropriately reported merely because telehealth technology was being used. But the modifier really is intended for when the service is happening across locations broadly, and not necessarily just when there's a technological mode of delivery. And that's kind of a bureaucratic answer, but the short of it is that visits should be billed when they're furnished. And if they're using technology but in the same location, then it's really not, then the telehealth rules don't govern it. Let's see, a couple other highlights. In addition to adding codes to the telehealth list, we removed several frequency limitations and other limitations on for particular codes through the interim final rule. We also wanted to make clear that the kinds of technology that can be used for telehealth services. There was some confusing language previously about telephones not being able to be used, and what the rules are for Medicare telehealth is that it requires the use of audio and video technologies, but certainly the sort of iPhones or iPads with commercially available applications are perfectly acceptable, and the HHS Office of Civil Rights that handles HIPAA, they have said that during the public health emergency that for HIPAA requirements that applications like FaceTime and Skype are acceptable for use for Medicare telehealth services. I also wanted to mention that in the interim final rule, we made payable pre-existing CPT codes for audio-only telephone services. So they're called the Telephone Evaluation and Management Services. And when video is not a component that is used in the provision of a service, those would be the appropriate codes to use. They're valued lower than the audio-video full visits, and there's no specific ED audio only, but the audio-only codes could certainly be used for emergency department physicians as well. And the valuation for those codes is based on recommendations that we received from the American Medical Association several years ago, I think over a decade ago, when those codes were initially created for the CPT process. A couple of other things to mention with a couple of minutes. We, in various Medicare payment systems, require face-to-face visits for things like certification of home health, and there's face-to-face requirements for reassessment for the opioid treatment programs, which is a new benefit under Medicare for beginning this year. And what the interim final rule did was to make clear that telehealth could be used in order to meet the requirements for a number of those face-to-face services. Finally, and I think this could be meaningful, we also changed the rules for the definition for required supervision, so that when the level of supervision that is required is what's called direct supervision, where the physician or the billing practitioner would need to be located in the same office suite or something like that. As the service being furnished, we changed that definition so that virtual presence through interactive communication technology could meet that requirement, particularly in cases where it makes no sense for the physician to be in a different location as the beneficiary. And I think I'll leave it there for now, unless there's something else. I'm looking at my notes, but happy to answer any other questions as well. And I think I can't recall who I'm supposed to hand it back to, so.
Ryan, thank you. So I think at this juncture, we have 15 minutes left, and we will proceed with the questions that were submitted. I'm going to hand it over to the Catchem team. I will say that, first of all, thank you so much for the participants that were able to join today. And if we can't get to your questions, we will we'll be collating them and be able to send the answers back through Jeff Davis at ACEP, as well as see if we'll be able to post them online for others that will be able to look at the session later. One question that did come up was with regard to the session being recorded. We are recording this session, and it will be available soon on the CMS website. Our website will be qpp.cms.gov, and it will be under the webinar link. And with that, I'm going to hand it over to Catchem if you can start maybe reading the questions to the panelists here, and we'll answer them as we can. Thank you.
Great, thank you. All right, so we've had a few questions come in. We'll start with the first one, asking if a registered nurse can conduct an MSC.
Hi, this is Jennifer, and that is covered briefly in our memo, and we do say, technically a registered nurse who's working in their state scope of practice requirements can technically do the medical screening exam. They would have to be approved by their governing body as a QMP. And Sarah, Karen, if you had anything to add to that, please feel free to do so.
All right, we'll move on to the next question. It asks, a patient recently presented to the drive-through COVID-19 testing and then asked to be evaluated for an eye infection. He did not want to get out of his car to come into the ED and asked for a provider to come to his car. Can you conduct an MSc in an automobile and still meet EMTALA obligations?
Okay, so let me say that. Sorry.
Oh, go ahead.
Oh, no, Karen, if you heard the question, I didn't hear it fully.
So I think the question is if someone comes to the hospital and is in their car and has an eye infection, can they be evaluated in their car for the medical screening examination? And we do not have specific location requirements for where that medical screening examination has to occur. So I don't see a particular barrier there. I would invite Dr. Wild, who's been on the call as well, to feel free to share any additional information you would have or additional insight you would have on that.
Yeah, and I'll ask Rena if she has any other opinion. But yeah, so the medical screening exam, as we said, could occur in a tent, and it probably could occur in a car if it were clinically appropriate to do so. The medical screening exam is going to depend, the appropriateness of it is going to depend on the symptoms that the patient is complaining of. So clearly, if it was simply to look in an eye and you did not need specialized equipment, such as a slit lamp or something like that, that might be appropriate. If, however, you needed more specialized equipment that was housed in the emergency department, then they might have to come into the emergency department. So the appropriateness depends on the nature of the complaint, and the medical screening exam has to be an appropriate screening exam that addresses that nature of the complaint. So it all depends on what the equipment is, what the nature of the complaint is, where that medical screening exam could occur.
And this is Rena. I have nothing else to add. I think, Rick, you had that stated correctly. Thanks.
Okay, great. Thank you. All right. Your next scenario asks, if they have a provider who insists that they can use telehealth in the ED with the patient and provider in the same ED but in different rooms, however, that means that their nurses will have to have face-to-face contact while the provider can be in another room and not have face-to-face contact with the patient. Can you clarify if that's correct?
Yes. So the answer is that yes, those technologies can be used, but the services wouldn't be billed as telehealth services.
All right, thank you. All right, next asks, did the EMTALA waiver remove required approval by hospital governing board for a QMP?
Can you repeat that question again, please?
Of course. It asks, did the EMTALA waiver remove required approval by hospital governing boards for the QMP?
This is Karen. The EMTALA waiver only addressed the referral off-site for the screening examination. It did not waive other requirements and processes associated with EMTALA related to, medical screening or having that screening conducted by a qualified medical professional that is approved. So it is more narrow, and that the requirements for the qualified medical professional approval by the governing body still apply.
All right, thank you. All right, your next question asks, will an archived version of this webinar be available online? And if so, when? Yes, it will be. It will be posted to the QPP webinar library, and we will send that announcement out through the chat box. However, your next question after that asks, for the memo issued on March 30th for waivers in regards to EMTALA states, this will allow hospitals to screen patients at a location off-site from the hospital's campus to prevent the spread of COVID-19. However, it sounds like now from the conversation, doctors cannot send them off-site for screening. Can you please clarify?
Hi, this is Karen again. I think just, as I shared, it is the 1135 waiver to be able to refer them off-site for screening. And so if there's if something we said made you think differently, please feel free to add it into the questions as well. And as was shared, we'll get a report out of those and be able to respond in writing for any areas that weren't clear or may have left a different impression. Thank you.
Karen, this is Rick. On page 4 of the guidance under hospital setting up screening off campus, the general rule is they cannot tell a patient who's already entered the ED to go to an off-site location for a screening. However, if there's an approved 1135 waiver in accordance with a state emergency preparedness or pandemic plan, that might be an exception to the rule. Is that correct? That's on page 4 of our guidance on March 30th.
Yes, and so there is a. Sorry, Rick, go ahead.
No, I'm finished. Over.
Okay. There is a requirement or the ability. We did release a 1135 waiver for the first time to be able to refer individuals off campus for the medical screening portion. So, and we can share the link to the waiver document with all attendees following this webinar.
Great, thank you. All right, your next question asks for a disaster plan. If notification is different than initiation of the hospital's plan, must the hospital have its individual disaster plan in effect for the waiver to be effective for that hospital?
So the waiver that became effective was effective on March 1st of 2020, and so there isn't really a requirement for the hospital's disaster plan in terms of the initiation of it or the notification. The blanket waiver is in effect. It does not need to be separately applied for, and it is in accordance with the state's pandemic plan. And so what we mean by that is really ensuring that you're working with your state and local public health officials to ensure that whatever off-site locations you're setting up is consistent with the community's plan for addressing COVID. So that's what we mean by, is not consistent with the state's plan, but it doesn't, triggering of the waiver is not separately tied to the hospital's disaster plan. So let me stop and see if any of my other colleagues have any comments on.
All right, so we'll move on to the next question. If you'd like to circle back, just let us know. This question is in follow-up to the point previously made about telehealth being only for situations where the patient and provider are in different places. So they ask, what about a situation where the patient and provider are both in the ED, but the provider is assessing the patient via telehealth only to prevent exposure and contamination of PPE?
So this is a similar question to a previous one, and in the use of the technology alone doesn't trigger the telehealth requirements, and so that service, if the service is being furnished that way, could be billed as any other service, and it's only the telehealth rules would only apply when the location of the patient and the physician are different.
Great, thank you. Okay, next, can you clarify whether the modifier is necessary when using video to do an MSC when you and the patient are both in the ED?
Same question and same answer. The modifier would not be used in that case.
Great, thank you. All right, we have time for just a few more questions. Your next one asks, have resident supervision requirements changed?
Yeah, so one of the things that we also changed in the interim final rule is that the virtual supervision can be used to supervise the work of residents, much like the changes in the direct supervision for physicians in private practice.
Okay, great, thank you. Okay, and your final question asks, is removal of the face-to-face requirement for opioid treatment programs limited to the duration of the public health emergency?
So that's a great question. So all of the changes that are in the interim final rule, or the ones for the waivers, are limited in duration through the end of the public health emergency. I think CMS recognizes that over time, some of these requests we may want to take a look at again, but the authorities that we've used to make the changes are all contingent on the public health emergency at the moment.
Okay, great. Thank you for that. So it looks like that's all the time that we have for questions today. So Rena, we'll pass it back to you to conclude.
Thank you. So first of all, I want to thank all the panelists for today for participating. I just want to express to all the attendees that here at CMS, we have really been trying to listen, and we have been listening and continue to want to have this outreach with you to hear the frontline issues that are occurring. We hope that this webinar was helpful. We will make it available publicly, as we mentioned, on our QCP website. And please reach out with other questions through your society, through the American College of Emergency Physicians or other societies, and we're happy to assist where we can. And I wish all of you to please be safe and well. I'll end with that.
Thank you all. Thank you all so much.